So dear students, we are starting with the part 3 of red and white lesions. In this, we are going to discuss the definition, classification, etiology, clinical features, diagnosis, differential diagnosis, and management of leukoplakia and erythroplakia. So all of these, they come in the must-know category. Firstly, we should understand what are the oral potentially malignant disorders. There are two terminologies under this head, that is the pre-malignant lesion and the pre-malignant condition. Now, under the pre-malignant lesion, the examples are leukoplakia, erythroplakia, proliferative varicose leukoplakia. They are the lesions which are morphologically altered, in which the oral cancer is more likely to occur than in the normal appearing oral. Whereas the pre-malignant condition, it is a generalized state which is associated with a significantly increased risk of cancer. And the examples for pre-malignant lesion, conditions are oral lichen planus, OSMF, parietal lesions in reverse smoking, lupus erythematosus, disc keratosis, and genital. Starting with the definition of leukoplakia, as given by the World Health Organization, it is a whitish patch or plaque that cannot be characterized clinically or pathologically as any other disease and which is not associated with any other physical or chemical causative agent except for the use of tobacco. Now, in this particular photograph, you can see on the buccal mucosa there is a white patch which is having a rough surface or a wrinkled surface. So this is an image of a leukoplakia. Let's see the classification. Classification can be according to the clinical description, according to the risk of future oral cancer risk, according to histology, and according to the extent. So according to the clinical presentation, leukoplakia can be homogeneous or non-homogeneous. According to the risk of future oral cancer, depending on the site where it is involved, it can be high risk site, low risk site, and the intermediate risk site. According to histology, depending on the dysplasia and non-dysplasia, and according to the extent, there can be localized or it can be diffused. Now, if we see as per the clinical description, homogeneous and non-homogeneous, homogeneous includes complete white patch, and non-homogeneous means a mixture of white and red patch both. Then, as per the risk of future oral cancer, the high risk sites are the sites which come under the central oval area of the oral cavity, which includes the floor of the mouth, the ventral surface of the tongue, the soft palate, and the pharynx. So these are the areas basically where the mucosa is non-keratinized, so it has a higher chances of penetration of the carcinogens. Whereas the low risk sites are the sites other than the oval area of the oral cavity and which are the high keratinized. And intermediate risk sites are the sites which come in between high risk site and the low risk sites. According to histology, depending on the report what we see histopathologically, dysplastic changes are there, then it can be categorized under the dysplastic condition. If there are no dysplastic changes, then it will be categorized under the non-dysplastic lesions. And according to the extent, the lesion, it can be localized, limited to just one area, or it can be diffuse, involving many areas of the oral cavity. Now let's have a look at the etiology of leukoplakia. The local factors which could be responsible are firstly the tobacco, which includes both smokeless and smoking tobacco. Tobacco has the greatest number of carcinogens available, which can penetrate the mucosa and cause various changes in the mucosa. Alcohol has a synergistic effect in causation of the leukoplakia. If patient is already a tobacco chewer and patient is consuming alcohol, then there can be a dual effect. The first effect can be a systemic effect in which the immunity of the patient is compromised, whereas the local effect can be in the form of changing the oral microflora, leading to xerostomia and other changes. Chronic irritation from any broken prosthesis or a chronic broken tooth can lead to a white patch in the oral mucosa. Candidiasis can be a superinfection on the already existing leukoplakia patch, whereas it can also increase the chances of keratinization of that particular lesion. Electromagnetic reaction and galvanism. This is seen when two dissimilar metals are there in the oral cavity as antagonists. So if such thing is there, then even that can lead to formation of a white patch on the buccal mucosa, which can have a very similar appearance to that of leukoplakia. Moving on to the clinical features. This is mostly seen in 35 to 45 years of age group or above that, and mostly the males are affected because the habits which we had discussed earlier in the etiology, alcohol and tobacco chewing, these are mostly common in male population, but now the trend is changing. Leukoplakia is equally seen in females as well. Buccal mucosa and commissures are the most common area to be affected. Buccal mucosa because the patient has a habit of keeping the quid, so that quid of tobacco and lime mixture, tobacco lime and betel mixture. So that mixture which is kept in the vestibule is in contact with the buccal mucosa, so indirectly the buccal mucosa is affected. And commissions are most commonly affected in the smokers. Smokers, they have habit of holding the the BD or the cigarette near the corner of the mouth, which can irritate the buccal mucosa over there and lead to commercial leukoplakia. Otherwise, gender-wise predilection has also been noted. Lips are most commonly involved in males, mostly related to the habit of smoking, whereas tongue is most commonly involved in the females. Color can be white or yellowish white, depending on the habit the patient has and the quantity of other food ingredients the patient has. Then the extent can vary from small, well-localized, irregular patches to diffuse lesions, and surface it is finely wrinkled or shriveled in appearance. As we can see in this particular lesion, this is the commissural area. Commissural area, just 1 centimeter ahead of the commissural area, there is a white patch, and the appearance of the patch is that the surface is wrinkled or a shriveled. The commissural leukoplakia is regarded as commissural if it extends posteriorly from the labial commissure over a distance of about 2 centimeter in triangular shape. As you can see over here, it's extended from the commissure towards posteriorly in the triangular shape. If we see the previous picture, if you could recollect the previous picture over there, it was not extending from the commissural area direct, but 1 centimeter behind it. So that could not be considered as a commissural uh, leukoplakia. The sublingual keratosis, that is the floor of the mouth and ventral surface of the tongue, if it is involved, then we call it as a sublingual keratosis. On the floor of the mouth, the most common appearance of the leukoplakia is the ebbing tide appearance. Ebbing tide, if you all might have been on a beach and over there during the low tide, you might have seen the sea water receding backwards. So what pattern is left behind on the sand is the similar pattern we see on the floor of the mouth lesions. Increased thickness of the mucosa is there because of excessive keratinization, and in cases of ulcerated and nodular leukoplakia, the patient can have burning sensation. The clinical types are pre-leukoplakia, homogeneous, nodular or erythroplakia or speckled, verrucous and proliferative. Now just try to understand each and every type. The pre-leukoplakia, which is the low grade or very mild reaction of the mucosa appearing as greyish white but not completely white with slight lobular pattern, and the margins are well demarcated or it can blend with the adjacent normal mucosa. The lesions are soft, translucent and thin. You can see in this image over here, this particular area is the pre-leukoplakia. Why? Because it is greyish white, not completely white, and it is the borders, although they are well defined, but in few areas you can see like over here and here it is blending with the adjacent normal mucosa. Next is the homogeneous leukoplakia. It is usually localized lesion of extensive white patches present a relatively consistent pattern throughout. We can appreciate on this particular ventral surface of the tongue, there is a thick keratinized leukoplakia which is homogeneous in appearance and having similar appearance throughout. And the surface is typically corrugated and with fine lines you can see over here, or fine wrinkles can be seen. Sometimes when papillomatous appearance can also be seen. So it is characterized by raised plaque formation consisting of single or group of plaques varying in size with irregular edges. And we can appreciate the color, which is white, or it can be slightly yellowish white. Try to compare this with the previous image of pre-leukoplakia. This is the buccal mucosa, in which you can see a big lesion extending from the corner of the mouth towards the retromolar area, and in few areas you can see it is more keratinized as compared to other areas. So a leukoplakial lesion can also have similar appearance of thick keratinization in few areas, whereas little keratinization in other areas. But again, this comes under the homogeneous leukoplakia because there is no red component but an entirely white lesion. Next is the nodular leukoplakia, which is also called as a speckled leukoplakia or a mixed red and white lesion. In this image, you can see a lesion, a mixed red and white lesion extending from the commissure towards the retromolar area. Similar lesion can be seen from the middle 1 centimeter posterior from the commissure area. There is a lesion, mixed red and white lesion extending up to 1.5 centimeter posteriorly. So if you see, there is a mixture of white component as well as a red component. There is a complete red component and in between there are white components interspersed, and these both are non-scrapable. Leukoplakia is a non-scrapable lesion. So such lesions which have white component as well as red component, they have high malignant potential. Why? Because this red component is nothing but the erosive or the ulcerative area through which the permeability of the carcinogens is increased. So if the patient is having such a lesion and is continuing the habit of taking tobacco, the carcinogens can easily penetrate through the mucosa, which will lead to increased possibility of the patient or this lesion being converted to malignancy. The next is the varicose leukoplakia. So you can see this is the ventral surface and the lateral border of the tongue, on which there is a thick keratinized, heavily keratinized homogeneous leukoplakia. So why? But if you see it closely, you will find few projections. Like over here, you can find over here, over here. So varicose proliferations above the mucosal surfaces gives this the term to this type as a varicose leukoplakia. And yes, definitely it is a heavily keratinized exophytic lesion. Next is the proliferative leukoplakia.